good afternoon. It's Dr. Reiner, your host of the Independent Doctors of Pahrump, and it's a live show on a Monday night, and I hope everybody's doing well. We should be having that call-in line number show up there, and we appreciate your viewing tonight. Pretty good show last time, and I thank Ray for the kind words. As you know, since we've had the show back on, we've covered a few serious topics, and one of those was the Cologuards and the fecal occult blood tests. I want to make sure that if you've watched that and you have any questions, please feel free to call in and let me help you with that. Also remember that if you're going to do the Cologuard, it has to be done within 72 hours of you making that sample and making sure that you get it to the UPS store on time. You cannot have too much stool in your bucket, 300 grams. And that's really about it for that. Much better test than the fecal globin. So hopefully you will find your way to get your provider. If you're over the age of 50 and you have insurance, it should be covered unless you have had a diagnosis of polyps or cancer, and then it will not be covered, and you could be charged the $500 to $600 for the test. The old poop on a stick kind of thing, the one you put in the toilet bowl, that's usually covered for nothing under most insurances, but again, very unreliable. We did talk about mammograms, and mammograms are done every 2 years unless you have a strong family history of breast cancer, a significant relative, things of that nature. And you want to make sure that you get those done locally. And the important thing about mammograms is comparison from year to year. You want to make sure that you get those done at the same facility so that changes can be noted. If you're getting them done at another state, make sure you get a couple records before you bring them to the radiologist here. It's significant. The significance is the change that takes place in the mammogram that's very important. And last time Ray had a comment about spontaneous remission, and we went into a very nice spiritual show, and I thought that was a very good way to talk about things that normally people don't talk about. And the take-home message from that, of course, is random acts of violence, which we see all the time, could possibly be combated with random acts of kindness. So if everybody was kind to other people and did the right thing when no one was looking, we would probably have less situations that would inflame people, even though that maybe is not 100% true, but I think other things have been tried. You can't pass laws to make people be nice. People just have to want to be nice. So I ask viewers, in light of that, to look at what you've done. Ask yourself a question. What have you done today that was a random act of kindness for someone? And I think if you kind of live your life like that, you can make the world a little bit better place. What's been going on in the medical community has been a little bit slow, probably because of all of the news about that's in the public sector with the trip to Singapore and all that good stuff with North Korea. One of the topics that tends to always come up is chronic obstructive pulmonary disease or lung conditions. I talk about it a lot. We treat a lot of patients with chronic obstructive pulmonary disease, and it is usually, again, in this community, age has a factor on it. There is a condition out there called alpha antitrypsin deficiency, alpha 1. It's a simple test that can be done in the lab, and if you have a family history of emphysema, and especially in someone who has not smoked or really has no significant risk for COPD, but it is in your family or emphysema, that would be a good condition to look at that might make you want to go down to your doctor and think about ordering this simple blood test. And there are some treatments that are available and things that can be done to prevent you from developing a very debilitating and terrible disease. One of the things that causes chronic obstructive pulmonary disease, and the reason it is called chronic and it is called obstructive, is that it progresses as you age. The reason is because your lung tissue it has these situations that develop where, let's suppose you're a smoker, and that's the most common cause of chronic obstructive pulmonary disease. What smoking does for a large percentage of the population is it creates a caustic environment in the lungs. Now, we know that if we work with our hands or we're out in the sun, the body has a tremendous way of compensating for the stress that we place on our tissues. That's why your hands will develop calluses if you work, or if you're out in the sun, you could develop a redneck, because the body is trying to protect itself from further damages from what is irritating its skin. Well, those same processes, we call that metamorphosis, is what happens in our bronchial tissue. Smoke is a very strong irritant, and it causes the cellular structure of our bronchial tissues to change. The cellular structures that normally exist in the bronchial tissues are a smooth columnar or columnar epithelium, a tall cell, and on the top of that cell, imagine it's a skyscraper for saking, and if you're looking at a skyscraper and you see that little antenna on top, that is what we call a cilia, or a hair cell. And these stack up right next to each other, and in between them is a globulate cell, and a globulate cell produces mucus. Now, we have to have mucus in our lungs. If we didn't, what would end up happening is every drop of dust or bit of inhaled particulate matter that we inhale would eventually plug up our lungs, and we would cease to exist. So the mucus, as these particles come into our lung, the mucus that coats our mucous membranes, which are made by these globulate cells, they drop onto there, and then the columnar epithelium with their nice little hair cells, they're beating in one direction, and they actually beat the mucus up out of our lungs where we swallow it, and it gets digested by the acid in our stomach. So we have this natural mechanism of clearing mucus on a regular basis. When you smoke, you cause the columnar epithelium to turn into what we call squamous cells, which are what our skin is. They're flat, they lay on top of another. But unfortunately, the goblet cells don't change. They do not respond to the stress of the inhaled smoke. So what happens in that sense is then you've got mucus being produced on top of a flat bed or a bunch of cells, and that mucus doesn't get beat up out of your lungs, it stays in your lungs. And there envelops the smoker's cough. Coughing is the only way to get rid of those mucus plugs that exist in our airway. And so when you smoke long enough, you develop a smoker's cough, because you're just clearing these globs of mucus out of there. Now, if you imagine that I've got this representing an airway, and we have this mucus plug sitting in here, when we expand our airways, guess what? This opens up, and the air flows over the mucus plug. When we collapse our lungs and exhale, it snaps shut. Normally, it should be left with a space of about that. It expands to this and this, always allowing air to flow. If you plug it off, it would be the same thing as having a balloon, and you're breathing the balloon on the end of a straw, you're blowing into the balloon is expanding, and let's suppose you put 100 cc's of air in there, and you exhale, and you only get out 70 cc's. You're trapping 30 of those cc's back into the balloon. Now, if you do that long enough, the balloon continues to expand, and it eventually pops. And that's what happens in our lungs. We have these small little alveoli, which are these little sacs, and this great exchange surface area, meaning that if we take multiple little circles and marbles and put them in a jar, we have a tremendous amount of surface area. If we expand it so they vanish, then we only have the surface area of the jar itself. And that is normally what happens with our lungs, and they continue to expand. Our lungs are limited by the rib cage, so we can only expand so far. So you'll see that the excursion that people take in their exhale is somewhat limited. And so that's why chronic obstructive pulmonary disease is a progressive disease, because of the mucus plugging and the air trapping. And we have certain medicines that are now on the market. A lot of them are very, very good, and the current level of care is a long-acting bronchodilator, with a anticholinergic or an anti-mucus producing, so that we limit the amount of mucus that is produced in the tissues, so we have less spasm and less mucus plugging, and we give a chronic open air bronchodilator to keep the lungs open as much as possible. And we tend to use less cortisone than we've normally used in the past. So we shifted away from using cortisone to using a long-acting bronchodilator along with an anticholinergic, and these are yielding the best results. I love COPD in the sense that you can actually measure the effect of a particular drug on the actual pulmonary function test. So when your provider starts you on a particular prescription, hopefully they will have you back to be able to see what kind of changes you've made while you've been taking that medication. It's a very objective measurement. You would take it's like taking a temperature. I know what your temperature is, and I can compare that over time. I know what your lung function is, and I can compare that over time. And I come up with a new number every time, and I can see the improvement. Either you improve or you don't improve. If you don't improve, great, we take the prescription away. If you do improve, we continue it. And so that's hopefully what we do with all of your things. So anyway, we're going to take a break, and we'll be right back for the second part of the show. Thank you.